Adhikari, who works in the Duke University Health System as a graduate researcher. And she's going to talk about environmental risk factors for Alzheimer's disease that I might call sort of new or emerging. And in particular, she's looking at the Environmental Justice Index that has been developed for the whole country. And she's been doing some really interesting work linking that to measures of MCI and dementia. So that'll be exciting. And now I'm going to share my screen to tell you a little bit about what we know about what I would call, sorry, I'm just trying to share this, established risk factors. So actually, let me try that one more time. Okay. Can you see a slide now? Great. Okay. So this shouldn't be too long, but it was really asked to just set the stage. And for those who don't know me, I'm a postdoc here at Duke in the psychology department, and I'm one of this year's Rec Scholars. So to remind you why we want to look at and think about risk factors, let's remember that our primary goal with dementia is prevention, primary prevention and secondary prevention. We want to catch people either before they have disease or as early as we can in the preclinical stage, well before they convert to MCI or dementia. And I was asked to provide a little intro today because a few years ago, I did a comprehensive literature review for risk factors for dementias, looking for those with good evidence in the literature that aren't just the ones we always talk about, but are ones that have had a lot of studies highlight. And I found that you could loosely organize those into 10 different conceptual domains, which are pictured here. Things like lifestyle risks, alcohol consumption, low physical activity, but also things that I called harmful events and exposures, which is where I might put some of the risk factors that Alisa is going to talk about, things like air pollution exposure, but also things that happen to you like traumatic brain injuries. And then, of course, there are those non-modifiable factors like genetic risks, a family history of dementia, APOE status. If you want to know which risk factors have the most weight of evidence, you can focus really just on those that have been selected for use in clinical risk indexes. So I'm now showing you the top 4 indexes in the published literature and the different risk factors that they've selected for. So these include, these risk factors, moving from left to right, are the CATIE, the Libra, a set of risks selected by the Lancet Commission, and the ANU-ADRI. If you look at the bottom, you'll see the number of risk factors they've selected for. And what I want you to notice is there's a lot of risks that we know about already. There's a lot of overlap among these different risk indexes, which have been designed for clinicians to use to know who should be selected into a research trial or who you might want to focus an intervention on. You'll see there's overlap, but there isn't consensus on what's the most important risk factor, which is one more reason I'm excited for Alisa's talk. What we see is there's general trends, but if you dig in a little, about half of these are what you'd call modifiable risk factors, lifestyle choices like diet and exercise, but also treatable conditions like depression and high cholesterol. So those I've highlighted in yellow. And the other half are either non-modifiable or they're pretty hard to modify. And so I've now highlighted those in green. These are things like age, sex, whether you're exposed to air pollution or pesticide, whether you've had a traumatic brain injury. When you look at the size of the risk effect, you see that having a given risk factor tends to increase your risk of dementia by around 20 to 90%. So potentially doubling your risk depending on the risk factor, the length of follow-up, the cutoffs you use to determine whether you've got a risk or not, how many drinks is heavy drinking. So here I've put a few of the risks that are potentially modifiable in order moving downward of increasing effect size. So heavy alcohol consumption appears to increase your risk by about 20% compared to moderate consumption. That is significant, but experiencing a traumatic brain injury in midlife increases your risk by 80%. These numbers, by the way, come from the Lancet Commission on Dementia, and they are derived from meta-analyses, many studies. So these we feel pretty confident in. But you'll notice this is just a handful of the earlier risks I showed you. And of course, we already know that there are interactions among these risk factors. In particular, there's modification by our non-modifiable risks, things like age, sex, and genotype. So I borrowed this chart from a 23andMe report that I saw that I thought, had nice figures. And it shows your lifetime risk of dementia. This one's for women by age and your number of ApoE4 variants that you carry. So what you'll see is on the left is your risk by age 65, by your right is by age 85, and the different color bars represent how many E4 variants you've got. Red is no variants, yellow is 2 variants. And what you see is risk increases by age, but also the influence of ApoE status increases by age quite a bit. And then this is the same chart, but for men. And you'll see the same general trend, but the risk is lower at each age for men than it was for women. And the influence of ApoE genotype appears to be stronger, both early in older age and later. So let me wrap up by saying there's a belief right now that if we can reduce the prevalence of risk factors for dementia, we can also reduce the prevalence of dementia, which makes sense intuitively, but it's only true if the risk factors prove to be causal and not just predictive. And so some of these things, this might be a little hard to see. It's a schematic from the Lancet Commission on Dementia that's designed to visualize the relative potential and importance of each risk factor we know about. And I would argue some of these might just be predictive because they tell us about who's on a pathway of disease, even if they don't cause the disease itself. If you squint, you can see hearing loss they put at the top as the most important, which could be an artifact of how we determine, cutoffs for hearing loss. But in general, this is the take-home message before Alisa's talk. When the Lancet Commission did their review in 2020, they decided that 60% of dementia risk is currently unknown. We don't really know what contributes to it. So I would argue there's a ton of room to understand established risk factors better, interactions among risk factors, but also to look at risk in a comprehensive way, look at emerging risk factors, understand environmental risk factors better. So with that, I'll get out of the way. I'm really looking forward to this talk. This is the slide I tend to put at the end in case you want to reach out. I'm going to stop sharing my slides and hopefully we can make a smooth transition.
Hi, everyone. Thank you for the kind introduction, Erin, and for setting the stage so nicely with the established risk factors talk.
Alisa, would you like me to introduce you?
Sure, if you'd like.
Okay. Hi, everyone. My name is Murali Doraiswamy. I'm a professor at Duke. Thank you, Aaron, for that introduction. It's my great pleasure to introduce Alisa Adhikari, who is just graduated from Duke, neuroscience major, did a year, gap year doing research in Alzheimer's disease before she goes to medical school. And she's very interested in the interface of the environment and health and environment and brain health. Many of you have heard the saying that your zip code is probably as important or maybe even more important than your genetic code. So with that, without much ado, Alisa, I want to turn it over to you for your talk.
All right, thank you both for the kind introduction and for setting up the talk so nicely, Erin. Thank you for that as well. Let me quickly share my slides. Okay, I think we're good. All right, so with the recent focus on, with the recent focus on climate change, as well as the exposome of Alzheimer's disease, I hope to be able to integrate these topics and perhaps speak a little bit more about the future of this work in my presentation. Okay, so to start, there have been a lot of studies published regarding the environmental and or social risk factors related to MCI, which Erin just went over a little bit. And these include exposure to toxins such as lead and nuclear waste, as well as other variables such as an education level, socioeconomic status, and things like that. However, very few of these studies have attempted to link a comprehensive set of these environmental or exposome variables, likely because such data has not really been available at a large enough scale for specific geographic areas. And as far as we know, no study has yet linked such comprehensive database to an AD clinical trial dataset. So before I get into the research part, I'm going to go over a little bit of the database that we use, just so that everyone is well oriented to the things that I'm going to talk about for the rest of the presentation. The database we use is called the Environmental Justice Index, or the EJI, as I will be referring to it. So this index was created in 2022 by the Centers of Disease Control and the Agency for Toxic Substances and Disease Registry. It's the first national geographic-driven tool that's designed to measure the cumulative impacts of environmental and social burden through the lenses of human health and health equity. And it builds on decades of past work, combining many existing forms of environmental screening tools and methods into one single database. So as a whole, the EJI contains 3 different modules, which are called the Environmental Burden Module, the Social Vulnerability Module, and the Health Vulnerability Module. And for all of those together, we'll combine a total of 46 individual measures. And each of these measures is given a percentile ranking from 0 to 1 in a particular census tract. And that percentile ranking is a comparison of that one census tract in comparison to all the other census tracts in the US. So 0, the percentile ranking is going from 0 to 1. 0 is the least amount of disadvantage, and 1 is the greatest. And the national median will be right in the middle at 0.5. So in creating the EJI, the goal was that policymakers and community leaders would be able to use this tool to see which areas may need more support or resources to reach the ideal of environmental justice, which is defined by the EPA as the goal to protect communities from disproportionate harm, provide equitable access to a healthy environment, and address structural and systemic barriers. And so I'm going to give a little bit of an example from the output of the EJI database, just so that we know what that looks like. So this is the view of that after I have searched for a particular address on the EJI Explorer. And here you can see the Durham County that's outlined in black here. And then within that, we have the various census tracts within the region that are color-coded and outlined in gray, so such as this one right there. And in the legend at the right, we can see that darker colors represent a higher EJI ranking and lighter colors are for a lower EJI ranking. So here we have a particular census tract in Durham County. And as you can see, this area is considered to be high in the ranking of environmental justice indicators, just based on this color coding. And on the panel to the left, you can see the individual metrics that are accounted for by the EJI, and this area has a high ranking for both environmental burden as well as social vulnerability in comparison to the other census tracts in the US. And below that, you can see more variables individually that make up the environmental burden module, which we'll discuss in a moment. But if I were to continue scrolling down, you would see all the individual variables one by one and like a value between 0 and 1 that is representative of the amount of disadvantage or vulnerability in that area for that particular variable. So this information in research could be important because residents from this area may have different living situations and environmental concerns and those that are recruited from a different area, even though they're in the same county, which is represented really well here. For example, they may have closer proximity to nuclear waste sites or have higher rates of poverty, which are important characteristics when judging the environmental impacts on human health and disease progression based on where a participant may live and the things they are exposed to on a day-to-day basis. All right, so as I mentioned, the EJI contains 3 different modules, and shown here are the variables that are contained in the environmental burden module. The social vulnerability and health vulnerability are up next, so we'll talk about that in a moment. But on the left side, we have the categories that make up the environmental burden module. We have air pollution, potentially hazardous and toxic sites, built environment, transportation infrastructure, and water pollution that make up the categories of the EBR, the environmental burden ranking. And then each of these categorical variables on the very left has at least one and likely more variables that make up that category. So for air pollution, for example, we have ozone, PM 2.5, disease particulate matter, and air toxics cancer risk. And then these variables are put together and averaged more or less to give a singular value for the category of air pollution. And that is true for the other categories as well. Then these categorical variables all of these will then be kind of accounted for to give one single ranking for the environmental burden ranking as a whole for that census tract. So all of these will be accounted for in that one number. And then we will have the social vulnerability module, which again has similar categories. We have minority status, socioeconomic status, household characteristics, and housing type on the very left. And then each of these categories has at least one and likely more of the individual variables that make up that value. And then to go on, like these variables and the categories will be combined to give a one number for the social vulnerability ranking. But the social vulnerability ranking, the environmental burden ranking, and the health vulnerability ranking will be kind of put together in the same way to give one value for the environmental justice index. So the EJI score will be one that is combining everything that is in the database as a whole. And then I won't really be discussing the health vulnerability module much in this presentation because it is not necessarily meant to be combined with other measures of health, since we do use cognitive testing and like MRI imaging methods for the rest of the analysis. We didn't really include the health vulnerability module as a factor. But just to give a little bit more context, it accounts for prevalence of 5 particular diagnoses in the area. So these include asthma, cancer, high blood pressure, diabetes, and mental health. That's that for the health vulnerability module. All right, so now that we have a good understanding of the basics of the EJI, I can move on to talking about the research and our efforts to link the EJI to the AD clinical trial. The aim of our study was to explore the linkage between the environmental and social factors in the EJI and the clinical trial data that we have. And we used data from the COGIT clinical trial, which enrolled 107 participants across the Duke and Columbia sites. And all of these subjects had mild cognitive impairment, and that was kind of a requirement of their enrollment to the study. The trial itself was a total of 78 weeks, and the data that we used was the baseline information and the change from baseline information for cognitive and imaging measures. During this time, participants were randomly assigned to either the computerized games or crossword condition, but that's not super relevant for the purposes of our analysis. The subject of our analysis were those from that original trial data set, and to get the information related to their environmental and social vulnerability in the EJI, we used their addresses and entered them into the EJI Explorer, like I had shown earlier, and we extracted the numerical variables from each of those metrics. And then all the data was combined into an Excel and then analyzed in R. All right, so here we have the baseline information for the 107 participants of the COGIT trial, which is a pretty typical MCI sample. And as you can see, I've divided them into 2 groups. We have the non-Hispanic white group and the minority group. This is a racial and ethnic minority sample and includes participants who have self-identified as Black, Asian, and or Latino. And the recruitment was done at 2 sites, which New York City and Durham, since we work with Columbia. And Columbia had recruited much more minority participants than we did at Duke. But as a whole, there's not a lot of cognitive difference between the 2 non-Hispanic white and minority groups, so which are shown here. The EMCI and LMCI are just staging differences in the early versus late stage of mild cognitive impairment. So there's not a significant difference between the non-Hispanic white and minority groups in that factor. And the same is true of the mini mental state exam and the ADAS cognitive exam, which are pretty common testing that is done for AD or other types of dementia in the clinic. So there's not a big difference, or no significant difference between those as well. All right, so here we have a figure just to give a brief overview between the sites with regards to the modules of the EJI. So we have NYC depicted in orange and Durham in blue. And for all of these variables, the environmental justice index, the environmental burden ranking, and the social vulnerability ranking, we have Durham being much lower than the national median at 0.5 for all of these categories. However, the participants that recruited from New York have on average significantly higher values for all 3 of these categories and are above the national median as well, especially for the EBR. And we can see here that the participants in New York City have more than twice the average exposure to environmental burden variables than the participants at the Durham site. And this is a similar graph that is shown for our non-Hispanic white and minority groups. We have the non-Hispanic white group being shown in green and minorities in purple, which will be a continuing theme for a few slides. But shown here, we can see that the minority groups have significantly higher average scores than their non-Hispanic white counterparts that are living in similar areas. And this is true for all 3 of these, are environmental justice ranking, as well as the EBR and the SVR as well. And it shows that our minority participants on average were a lot more disadvantaged in all 3 of these categories as compared to their non-Hispanic white subjects, which points to a disparity in environmental and social exposure for these 2 groups. So here is a breakdown of all the indicators in the environmental burden module for both groups, non-Hispanic white and the minority groups. And again, we have the averages of the non-Hispanic white group being shown in green and the minority participants shown in purple. We have the cumulative EBR score at the very top here. And then clockwise, we have air pollution, ozone, PM 2.5, and so on. And then this red arrow is meant to point to the national median at 0.5. So anything above that is going to be worse than the median. Anything below that is going to be better. For air pollution as a whole, we have most of our participants having relatively high scores in this area, regardless of their racial, ethnic, minority status. But in other areas we have, such as like proximity to airports, as well as proximity to lead and coal mines, we have relatively low values, indicating that many of our participants didn't really have exposure to these factors at all. But looking at this graph as a whole, the non-Hispanic white group has lower numbers than our minority population for many of these indicators, and a lot of these are significant, which we can see with the little asterisks next to the variable names. Generally, the values for the non-Hispanic white group is generally between 0.4 and 0.6 around the graph, though there are, of course, some exceptions with the air pollution, for example. However, the minorities are particularly hitting 0.7 and higher for many of these indicators of environmental burden. And for example, we have the air pollution being the the top 20% worse than the nation. And this is even worse for like the disease particulate matter and the air toxic cancer risks as well. Also, the subjects who identified as minorities tended to live in areas with more homes that had been built pre-1980. And this is an indication of exposure to asbestos as well as lead poisoning, since many of the homes didn't have regulations around that at the time. And many of these differences are significant, again, with the asterisk, so next to the variable name, and demonstrates that on average, our minority population tend to live in areas that give them increased contact with these environmental toxins, and is a disparity in their exposure, as well as their environmental justice. So this is a similar chart, this time shown for a social vulnerability ranking. The comprehensive SVR is at the very top, again, here. And going around, we have the variables that make up the module. So the racial, ethnic minority status, socioeconomic status, poverty, and so on. And again, we have minorities shown in purple, and we can see even more clearly than for the EVR that there are quite a large disparity in the social vulnerability ranking between the minority participants and non-Hispanic white subjects. And it's particularly evident here in on this side with the socioeconomic status, poverty, lack of high school diploma, and lack of internet access, among others. And this continues to demonstrate the disparity in social vulnerability between the two groups. Going forward a little bit, I'm going to be showing a relationship, but here's the relationship between the EVR, which is shown on the x-axis, and the ADAS score from baseline to endpoint on the y-axis. And as you can see in the graph, as well as with the correlation of the p-values on this side, there's not really a super strong correlation between these variables at all, which means that in our sample of participants' EVR ranking, based on the area in which they lived, was not really a strong predictor of the longitudinal change in their ADAS score. And I did similar tests with the other cognitive variables, such as the mini mental state exam, the functional assessment questionnaire, as well as the EJI metrics, and got similar results, as there was not really any strong correlation, and the p-value did not really indicate significance in these areas. All right, so to conclude, our study demonstrates the feasibility of linking the EJI to an MCI clinical trial dataset, and it also revealed differences between the two sites, between New York City and Durham, as well as between the minority and non-Hispanic white participants, marking the disparity between the two groups. It's the first study that we know of to link these 40 track-specific environmental and socioeconomic variables to cognition and functioning. And we do also recognize that there are limitations to this work. For example, our sample study was relatively small, as 107 participants, and all of them were chosen for the original study based on the fact that they had mild cognitive impairment, which presents a rather limited cognitive range. And we didn't have any participants who were normal or who had crossed into the dementia or AD category yet. And going further into that, we didn't have longitudinal locational data available for the subjects, just the address at which they were living during the time of the study. And the EJI itself does not contain data from the past, which presents another limitation of the database, which means that we can't use these measures to determine lifelong exposure to environmental or social vulnerabilities. Additionally, for the EJI itself, there's a variation in the way that the variable data is collected. So some of the variables have been collected over different periods of time, which means that the data is kind of like a patchwork of these measures, and you can't really account for them all at once. And lastly, because the EJI only covers geographical space as big as a US Census tract, we cannot really account for variability within that geographic area. So we don't have access to a lot of granularity or individualized data. In the future, examination of these correlations may yield more conclusive results if done with larger observational data set that contains individuals with more cognitive range, and may yield more novel insight into how the environment, the climate, and socioeconomic factors may impact cognition and/or health longitudinally. And further collaboration between clinical and environmental researchers may enable us to identify more variables and new variables to get more granular data as well. So that's it for the presentation, but here's some information about the grant. I'd like to thank my collaborators as well as our advisors at the EPA for their work and their advice on this project. And thank you all for listening. And I guess we can open it up to questions now. Let me stop sharing. Okay.
Great, thank you so much. Really lovely presentation. Terrific. And so I'm going to see if there's questions. You can put them in the chat or raise your hand, and I'm just looking around here. Get my view of the gallery here so I can see better. Yeah, there we go. Any comments or questions there?
I see Aaron has his hand raised. So
there he is.
Yeah.
Thank you, Aaron.
Sure thing. I thought I'd jump in. I think this is a really exciting avenue that you're taking this. I do environmental and dementia research, so it's exciting to me to see people stepping into that. So you've got a really nice linkage of data sets here. It looks like your main effect size, the R value you put up didn't surprise me. You know, we often expect to see small effects, but in total, they should aggregate to be meaningful across the population. And your p-value could be the consequence of a small sample size. But I'm curious, it looks like you looked at the EGI as a total composite index, but you should also have the ability to look at individual components of that index, which when you aggregate, their influence might be washed out. So I'm curious if you've started to look at individual components or if that's something you're going to do later. For example, there's some really interesting work that your growing up in a home with lead pipes is predictive of whether you experience faster cognitive decline later, but only if I think it's only if your water is more acidic than the average. So there's a lot of complexity here that is going to get washed out in a full EGI. So I'm curious what your follow-up plans are.
Yeah, for that particular measure, we did run it with some of the categorical variables and didn't really find much of significance by itself. Again, like you said, if you aggregated them together, maybe that would change how we could read it. But for the most part, looking at the categorical variables and the other things of the EGI, we didn't see a lot of significance, and it's kind of hard to like do the level of granularity that you just talked about just now, just because like the way that we're looking at this data, it's very much on a census tract level, and we can't really get down to like the house or like an individual level, which kind of presents a little bit of limitation to the way that those can be read. Yeah.
Thank you.
Did any of your findings surprise you?
That's a good question. Well, not a ton. I wasn't sure how. It was an exploratory analysis, so I was kind of going into it with kind of an open mind of like what I was going to find. I hadn't really worked with such like environmental level data before on this scale, so it was kind of an exploratory analysis in that way. I can't really say that anything particularly surprised me so much, except maybe when I was doing the Durham versus like New York City analysis, I wasn't expecting there to be such a great distinction in like the environmental burden of New York City being that much higher than Durham, for example.
Thought that was interesting too.
Yeah.
Alisa, can you also mention the area deprivation index findings? And I know you compared that to the EJI. Can you touch upon that a little bit? Because many people in the audience may be using the area deprivation index as a metric.
Yeah, I also had done it with the same kind of similar analysis with the ADI as well. The thing is with the ADI that only contains measures of like social vulnerability and not necessarily the variables that are in the environmental justice index for environmental burden. And then again, the variables are not given in the ADI individually, so you only get two different measures, which is the state and national, like the rankings within the state and then nationally. So that was a bit of a limitation because we didn't get much information besides those two data points. But for the most part, we got similar results in terms of the differences between New York City and Durham. And then again, with the minority versus non-Hispanic white subjects, we got similar distinctions and disparities between those two groups with the ADI as well.
Other questions? Looking around. Thought I saw one somewhere.
I forget if you mentioned this, but can you tell us what some of the next steps are that you're most excited for, that you think hold the most promise?
Well, that's in terms of kind of, well, I hope that we would be able to kind of use this in a larger data set, just because as I mentioned, our data set was relatively small, and then the cognitive range again was all of our participants had cognitive impairment. So to do it in a larger observational study with more subjects that are like normal MCI and have other AD or other types of dementia would be useful, I think, and we probably get more conclusive results that way than just looking at one particular, I guess, type of person for the most part. But yes, again, that's with the EJI itself, but looking at it in a bigger scale, I would hope that like at some point, we're moving to more individualized, more granular kind of data to be able to work with like on a clinical level, so that we can give one patient like clinical advice regarding their particular dynamics of their situation, rather than being able to look at this kind of larger scale data.
Yeah, I think that makes a lot of sense. As I recall, your presentation mentioned ADNI, and that'll be a nice data set because you can actually look to see whether your risk factors predict conversion to MCI or dementia, but also time to conversion. And I would encourage you to think of the ADI. I know it's built on socioeconomic indicators, but we know those are so intertwined with our environmental risks that a lot of us are using it now as a good proxy that we're going to say, do we see effects with conversion just using the ADI? And if so, that can motivate follow-up studies or things like that.
Yeah. The ADNI study, I know they added the ADI recently, so hopefully they can, but like the EGI is a lot more data than the ADI contains, I guess. So that's another larger step for them.
Yeah, and it has things no one's looked at, like distance to a Superfund site. I've never seen a dementia study consider that. It could well make a difference. It could be too crude a measure, but across all the ones you showed us, I think the opportunity for discovery should be high.
And more in a little of a practical question here is about collaborating with a site in another state that's very, that it has some differences from your site and complications there, or any difficulties with managing this project in that way.
Well, I wasn't here for like the part where they ran that clinical trials data itself. So I would say Dr. Duraswam probably has more better answers for that. But in terms of running the EJI itself, it wasn't terribly complicated because we had all the subject addresses kind of with us. So it wasn't too complicated there.
Yeah, no, I think it's very important if you're planning to implement this in a multi-center trial. Obviously, it's revealing that there are differences at site level that we would not have anticipated that could confound, site by treatment effects or site by outcome effects, which people don't think about because they don't think about the environment being different in different sites in a multi-center trial. They assume they treat all the sites kind of, even though they run site by treatment analysis in a multi-center trial, they often don't assume that sites vary this much in terms of their exposure to various environmental hazards. So that's one of the insights here. We're not advocating people select patients based on the EJI, but it may be useful to do a deeper phenotyping of the exposome. Of course, getting a detailed clinical history lifetime exposures, all that is very important because the EJI is, like Alisa mentioned, not as granular as we would like, but it gives us objective measures that we would not be able to gather just from a clinical history alone.
It's really great. I agree. This is just a fascinating project, and we really appreciate the presentation today. It's really exciting, and we know this is just a small part of the whole R01, so we're hoping to hear more about this again later as the study progresses. Really wonderful work. So thank you. I'm gonna just ask if there are other questions around. I don't want to miss anybody, or other comments, or any last points you'd like to leave us all with.
By the way, Alisa has submitted a second paper. I know many people in the audience. I know I see Brenda Plasman's looking at pesticides and other toxic elements. Alisa has just submitted another paper asking the interesting question: how should clinicians integrate climate medicine and the environmental phenotype, if you will, into a routine practice? Because that's the next step, and how should clinicians deal with this issue, because it could become an increasing issue in the future. So I don't know, Alisa, you have any? I don't want to put you on the spot. It's an easy question. It's not an easy question, but.
Yeah. Well, for that, we were kind of looking at a case report for one of the participants in this study, and just kind of how her environment has exacerbated her existing health conditions. And it's kind of the way that climate change is progressing. It's kind of important that clinicians are taking into account when discussing a patient's health with them. And so just a question of how could they talk about that with their patients? How could clinicians even gain the knowledge of environmental variables and how they correlate with particular health effects and things like that? Just a consideration.
Well, as a clinician that sees a lot of people every day who have various stages of dementia and so forth. I mean, I think any risk factors that we can identify, or any exacerbating factors, I think to help us guide our patients is always welcome. And particularly since we are, not able to provide much treatment at this point, although that's hopefully changing as we look at new clinical trials and so forth. But again, like most treatments, I believe we're going to find that the treatments are going to be good for some groups and not others. And there's always a multifactorial effect here. And so I think the work here could really play a role in giving tools to the clinicians for their patients. It's very important. So we encourage you to continue on this great work.
Thank you.
Thank you. And good luck to you, Alisa. It was a really lovely, wonderful presentation, and we hope you'll really do great next year.
Thank you.
So applause, and thanks to everybody for giving us their time today with our Ideas Forum. We're just delighted to have you. And again, don't forget to send in an abstract application for the Slam Dunk. And again, that's due at the end of May. If there's any questions, please reach out to Jackie Goking or me or Kyle or Ellen Roberts, and we'll be happy to help. But that would be really great. And oh, this is great. We'd love to see that paper, so thank you. So we'll put that down too. So good luck to you, and look forward to seeing everybody next month. Thank you.